Hello and welcome to this question and answer webinar on the management of recurrent cystitis, a problem that every doctor has doubtless seen and that certainly fascinates me. This educational webinar is brought to you by OM Pharma and is hosted by EMG Health. And I'm your moderator for today, Dr. Jonathan Sackia. Today, I'll be talking to three experts following their symposium with OM Pharma at the EAU Virtual 2020 conference. Our speakers are Professor Tommaso Cai from the Santa Chiara Regional Hospital in Trento, Italy. He spoke about the disease burden of recurrent cystitis and the importance of prompt diagnosis and risk identification. Benvenuto, Professor Cai. Professor Gernot Bonkat, who's the chair of the EAU Guidelines on Urological Infections, is from the Alta Euro AG in Basel, Switzerland. He shared his insights into state-of-the-art management of recurrent cystitis. Guten Tag, Professor. And last but not least, Professor Dr. Florian Wagenlehner from the Justus Liebig University in Gießen, Germany, who spoke at EUA about the place of immunotherapy in the management of recurrent cystitis as an attractive alternative. Willkommen, Florian. So welcome to Professors Cai, Bonkat, and Wagenlehner, and thank you for joining me for today's webinar. And I'd like to kick off with a question for Professor Cai. Tommaso, what tools are available for a prompt and correct diagnosis of acute symptomatic cystitis?
So the diagnosis of acute and complicated cystitis is based on the presence of lower urinary tract symptoms, such as dysuria, frequency, and urgency, and the absence of vaginal discharge. In other words, the diagnosis of acute and complicated cystitis is based on the clinical evaluation. Recently, Dr. Alizhanov from Uzbekistan validated a self-reporting questionnaire named Acute Cystitis Symptom Score, in which it uses a lot of questions in order to evaluate and assess the impact of symptom and the impact of symptom on quality of life in women with suspected uncomplicated urinary tract infection. This questionnaire, this tool, is able to help patients and doctors make a differential diagnosis of lower urinary tract infection from the other urological disorder. Moreover, this tool is very, very useful tool for use and for monitoring treatment efficacy. This questionnaire has been evaluated in several languages, several European languages, and in several populations with a different clinical setting. As you can see here, the CSS questionnaire is very easy to complete, to use, and can be recommended for clinical studies and practice from initial diagnosis and monitoring treatment of acute and complicated cystitis. The questionnaire can be downloaded directly from the web.
So thank you very much for those insights, Professor Cai. And at some point, I'd love to discuss how the acute cystitis symptom score could be more widely disseminated so that women around the world would know about it, right? So it's not just a tool for doctors. But I'd like to pose another question for you, and that's, how can we predict UTI recurrence?
So I would like to start from the definition. What does it mean, a recurrent urinary tract infection? Recurrent urinary tract infections are defined as a symptomatic episode of acute and complicated cystitis with a frequency of at least 3 episodes in 1 year or 2 symptomatic episodes in the last 6 months. Recently, we developed and validated a nomogram named LUTIRE, Lower Urinary Tract Infection Recurrence Risk Nomogram, that accurately predicted the recurrence risk of urinary tract infection at 1 year and can assist in identifying women at high risk of symptomatic recurrence that can be suitable candidate for a prophylaxis strategy. The nomogram variable included are the number of sexual partner, the bowel function, the type of isolated pathogen, the hormonal status, the number of previous recurrent urinary tract infection in the last year, and the previous treatment of asymptomatic bacteriuria. For instance, in a woman with one sexual partner, with a normal bowel function, with an E. coli, for example, isolated from the urine, in premenopausal status, and in case of more than 3 episodes of urinary tract infection in the last year, and with a previous treatment of asymptomatic bacteriuria, this woman has a total LUTIRE nomogram score of 130, with a 60% of probability to have a new episode of acute uncomplicated cystitis in 1 year. On the basis of LUTIRE score, we can stratify all patients into 3 categories. Low-risk patient with a probability between 20 and 45% in that only counseling about UTI risk factors is recommended. Moderate risk category with a probability between 46% to 70% in which an active prophylaxis strategy is recommended in all motivated patients, and finally, in high-risk patients with a probability of recurrence more than 70%, in this case, in this patient, an active prophylaxis is highly recommended. In conclusion, the prediction of recurrence risk is an important tool in the management of recurrent UTI patients.
So this is a very elegant, very simple and straightforward methodology. Even a simple surgeon like me can understand it. What can we do to increase awareness of this amongst doctors and patients?
We can increase the awareness of doctor and patient in order to share the information about risk factor. We need to improve our antibiotic stewardship principle, and we need to reduce the use of antibiotics. This is a very important point. Improve antibiotic stewardship, decrease the use of undiscriminated use of antibiotic, and improve the knowledge about the UTI risk factors.
Yeah, the point you make is critically important. And during the COVID pandemic, it's become apparent that antibiotic stewardship is going to become only more and more important. The RECAP study, can you talk a little about that?
So, in order to increase the awareness of recurrent cystitis, in order to ameliorate the prompt diagnosis and promote the implementation tools to predict the recurrence risk in acute cystitis, together a panel of experts, we are working on this and other topics, such as antibiotic stewardship and the optimal management of UTI in the context of RECAP program. RECAP stands for Recurrent Cystitis Awareness Program, and on board of experts include 12 international key opinion leaders, ranging from urologists, gynecologists, and infectious disease. And in this board, we try to improve our knowledge about urinary tract infection management, and in order to improve the knowledge and in order to ameliorate the management of the disease in accordance with the patient aspect and the patient desire.
Professor Wagenlehner, could you talk to us about which antimicrobials should not be used to treat uncomplicated cystitis and why, which is a perfect segue from what we were just discussing with Professor Cai?
Yes, amongst the many antibiotics that have been tested in clinical trials in the treatment of uncomplicated cystitis, in the last years, we lose more and more antibiotics or antimicrobials that can or should not be used to treat uncomplicated cystitis. And this is for a number of reasons. One reason is the negative effect on the microbiome, which is called collateral damage. And this goes hand in hand, as we already heard, with the more broad consensus that we want to use antibiotics in the sense of an antimicrobial stewardship, that we want to use antibiotics that protect the microbiome instead of destroying the microbiome. So that is one number of reasons. The next reason is for increasing antimicrobial resistance. And another reason is for side effects due to the treatment of the individual subjects. So these aspects have been included now in a number of guidelines. And for example, the EAU guideline has specifically also excluded aminopenicillins and fluoroquinolones for the treatment of uncomplicated cystitis. So I would first focus on the fluoroquinolones. Fluoroquinolones are not considered a first choice treatment for several reasons, as I already have mentioned. One of the reasons is that fluoroquinolones have a rather high negative effect, have a rather high collateral damage on the microbiome. So they select on the one hand for resistant and multi-resistant organisms, and on the other hand, they might reduce the number of beneficial pathogens, which is the collateral damage of the microbiome. Secondly, already in 2016, the FDA and later on the European Medicines Agency already restricted the indication of fluoroquinolones for the treatment of uncomplicated cystitis due to side effects, severe side effects. And these severe side effects comprise a number of different, rather severe effects on the neurotoxicity, on the tendons, on several functions, detrimental functions of the body, and therefore it is no longer indicated to use fluoroquinolones for the treatment of uncomplicated cystitis. And in addition, depending on the region where we look at, but in general speaking, most of the European countries have rather high rates of antimicrobial resistance, of fluoroquinolone resistance, exceeding 20%. And therefore, this is the third reason why fluoroquinolones are not a first-line treatment anymore for uncomplicated cystitis. And the second, in the past, rather frequently used antibiotic substance is penicillins, aminopenicillins. Now, aminopenicillins have been very effective, have been rather safe in the past 20 to 30 years, but we face mainly antimicrobial resistance in uncomplicated cystitis exceeding 50% of patients having this disease, and therefore aminopenicillins primarily are excluded for the treatment of uncomplicated cystitis due to the high resistance. Now, aminopenicillins also, like every antibiotic, exerts a negative effect on the microbiome and has, for that reason, side effects such as diarrhea or other side effects. But I think the resistance situations is the situation that is mostly effective nowadays in most European or in all European countries, why aminopenicillins should not be used as a treatment for uncomplicated cystitis, because treatment in uncomplicated cystitis is always empirical.
So, well, thank you very much for that, Florian. Towards the end, I'd like to come back and talk a little bit more about antimicrobial stewardship and some of the impacts, you know, as a colorectal doctor who saw a lot of colorectal disease, seeing patients with pseudomembranous colitis, which, as you know, we all know is a fatal condition, and to discover that it was induced by taking an antibiotic for an uncomplicated cystitis, which of course makes it doubly tragic. So I'd like to move on and ask Professor Bonkat. I'd like to ask you about immunoprophylaxis with OM89. What is this, a vaccine? Can you talk to us about this?
I can, my pleasure, Jonathan. So most important during this time in the COVID situation where many people worldwide are fearing a vaccine, I would like to state that OM89 is not a vaccine, it's more an immunomodulation. A vaccine, for example, targets a specific pathogen and stimulates the immune system to respond to that pathogen on exposure, largely via the adaptive immunity system. OM89, to the contrary, is an oral immune therapy. And now you have to understand how this drug, or what is this drug made of. And this drug is made of components of 18 different E. coli strains. And these components are boosting the immune system through innate as well as adaptive polyclonal immunity. And however, its mechanism of action is not involved in the establishment of B-cell memory. This means that it's not a vaccine, it's really more immune prophylaxis or immune modulation. What is interesting, its components consist out of 18, as I mentioned, 18 different E. coli strains, but it's working not only against the most frequent pathogen in urinary tract infection, E. coli, it's also working against other strains. Is that we know from initial studies that the repeated intraperitoneal or oral administration of a OM89 in mice produced specific antisera, mainly containing IgG. And these antisera was found to bind to each of the bacterial strains used for the preparation of OM89, but interestingly recognized some bacterial cell wall components of other gram-negative bacteria as well. And this was able to bind not only to E. coli, but to other gram-negative bacteria such as Proteus mirabilis and Klebsiella pneumonia, for example, as well. And based on our knowledge and from my personal experience as well, this drug is working not only in the case of recurrent E. coli cystitis, but for example in Klebsiella pneumonia as well. This is a study performed by Krebs, and what this study was showing as well, it's a side report, is that in these spinal cord injury patients, administration of OM89 was able to reduce recurrent urinary tract infections, but not only E. coli, but as well the non-E. coli urinary tract infections to a similar rate. These slides just summarize how we understand the mechanism. So OM89 is taken orally. It then stimulates the antigen-presenting cells in the pia patches, resulting in the activation of immune cells. These immune cells are migrating to the urinary tract, and in the lower urinary tract, these immune cells are leading to an increased total IgG and IgA antibody production, therefore reduce bladder inflammation and increase levels of interleukin-6 and interferon gamma, and an enhanced pathologic activity and delayed apoptosis of the phagocytes. All in all, resulting in an enhancement of defenses against recurrent UTIs.
Well, thank you very much for that. I mean, it's fascinating, and it suggests that there's a whole new field of approach to microbial infections, right? About a different way of thinking about treating them. It's absolutely fascinating. I'd like to move on and ask Professor Wagenlehner for this question. Is immunoactive prophylaxis well tolerated, this therapy? Can you tell us about that?
Yeah, thank you, Jonathan. This is a very valid question because, as Professor Bonkat has alluded, the mode of action of the oral agent is via a host pathogen interaction at the pious patches in the small intestine, leading to a immunological reaction which eventually takes place in the urogenital system. And therefore, possible side effects could certainly be gastrointestinal or by even immunological side effects. But we have several data. First, of course, data from clinical trials, and there are more than 470 patients that have been studied in depth, in detail in clinical trials. And as you're all aware, in clinical trials, all kinds of side effects and adverse events are meticulously protocoled, and therefore in these clinical studies we have a very in detail and in-depth sense of adverse events due or not due to the study medications. So all adverse events are protocoled here. And from these clinical trials, we see that the OM89 has a very favorable safety profile with a rather low overall incidence of adverse events, and they're very similar as those observed in the placebo group. For example, there were no very common adverse events. There were, and this is by definition, common adverse events which are between 1 per 100 patients and 1 per 10 patients. And this was mainly gastrointestinal disorders such as diarrhea, dyspepsia, and nausea, or also headache. But again, this was in a similar percentage as in the placebo group. And then there were very uncommon adverse events such as pyrexia, rash, or hypersensitivity. But also, again, this was in a similar percentage as in the placebo group. And then we have long-lasting data from post-marketing surveillance data. And there is a almost 40 years history now from OM89, where OM89 has been used in the population. More than 5.8 million patients have been treated with OM89. And in these almost 6 million patients, only 2,000 adverse events were reported in less than 1,000 patients. So that makes a percentage of around 160 cases of very moderate or low adverse intensity per 1 million patients treated. So based on these data, I think we can rather safely conclude that the safety profile for OM89 is favorable, and the observed frequency of adverse events related to OM89 is very low, and in the clinical trials was comparable to the placebo arms.
So if you look at those data, and my prior comment about pseudomembranous colitis and all the other side effects of conventional antimicrobial therapy, it's a very promising safety profile. And so this is a question for Professor Bonkat. Based on your experience and your opinion, how do we choose the right patient who will benefit from this kind of immunotherapy?
So what I can say so far is, on my clinical experience, the ideal patient seems to be, from the data as well as from my personal experience, the postmenopausal woman. And we all know that postmenopausal women are at higher risk of recurrent cystitis, because mainly about the reduction of the hormone status, etc. And we know that the OM89 is working. This has already shown a pilot open label study of postmenopausal women receiving OM89, and we see that there's a reduction about 65% in the mean UTI recurrence rate compared with the period prior to study entry. And we have another studies which have shown the efficacy of this drug. This is why, for example, in the Latin American guideline, there's a flow chart here presented that the OM89 is recommended in prophylaxis in postmenopausal patients. It's a combination with estrogens, and in patients, premenopausal patients, it's without the application of vaginal estrogens is recommended. And only in case of failure, last line means like antimicrobial treatment should be offered. So this was the main indication for me. But now we are receiving more and more data that another patient groups might benefit from this drug as well. So OM89 has shown efficacy, for example, in patients with spinal cord injury and recurrent and chronic UTIs. And we have a placebo-controlled crossover double-blind study. We have a recent retrospective cohort study using the booster posology, which is meaning after 3 months of treatment, then you have a break of 3 months, and then you have to treat for 3 months only the first 10 days of a month. And we have as well a feasibility randomized control trial for the prevention of symptomatic UTI in patients with chronic neurogenic bladder dysfunction. On the right side, you can see the data from the study performed by Krebs, and here you can see that there was a reduction of the proportion of patients with recurrent UTIs significant compared to patients who has not received the drug. And all in all, you can say that you can see that the recurrent UTI decreased significantly from 93.4 to 59.6 during the immune modulation therapy, whereas the proportion of patients without UTIs increased significantly. So it might working as well. What I can show here as well is feasibility randomized controlled trial for the prevention of symptomatic UTI. And in this study, the main outcome was that based on the study findings, such a trial might be feasible to perform. And therefore, the study results are so promising and consistent with previous research and support undertaking a fully powered study, which means we have to involve more patients, all in all 350 patients or participants.
So I'd like to thank our 3 participants, and I'm going to ask each of them for a final thought, a parting thought, if you will. And whilst they're gathering that parting thought, what I've learned from this is the value of the acute cystitis severity score, the fact that antimicrobial resistance is a problem that thankfully everyone is thinking about, that OM89 seems to be an extremely promising approach to prophylaxis for these at-risk patients. And at this point, I'd like to ask, first of all, Professor Cai, and then Professor Wagenlehner, and then Professor Bonkat, if they have a parting thought for us.
So I think that now we are at work against bacteria. We are at work against resistant bacteria. And this is the time to change our point of view, of course. We need to reduce antibiotic use. We need to start to consider that the uncomplicated cystitis is not a simple disease, but is a very important disease that is able to impact the patient's quality of life in severe sequelae with a lot of consequence, lost day from work, reduced quality of life, and so and so. So we need also to improve the awareness among doctors, among physicians, among the general practitioner about the need for correct antibiotic use and avoid the unnecessary antibiotic use. Moreover, we need also to improve our knowledge about all tools that is able to improve our knowledge about risk factor and about the prediction of recurrence risk, because the recurrence risk is an important cause of decreasing quality of life. Moreover, we need to start to regularly use in our clinical practice all antibiotic sparing approach that is able to improve our antibiotic stewardship.
I think we are entering or have entered since the last years an era where in some countries we already have a post-antibiotic scenario, and therefore every strategy that helps in reducing antibiotics is certainly very helpful and needed. And as uncomplicated cystitis and recurrent cystitis is a very frequent entity, it is a very welcome strategy that we have these immunostimulation possibility where we have evidence to reduce the episodes, the number of episodes, and the number of antibiotics used in these patients. And therefore, it is a very important contribution to fight antimicrobial resistance and to avoid a post-antibiotic era.
I would like to add as well what Professor Wagenlehner has mentioned is the problem of the antimicrobial resistance, which is rising worldwide. We have now data which are facing a scenario that in 20 or even in 10 years, antimicrobial resistance might cause more deaths worldwide than cancer, for example. And coming back to the setting or to the complex situation of urinary tract infections, it might be that perhaps men might think that cystitis is not a big deal, but the frequency of cystitis and the patients, the few patients are suffering from it. And besides the suffering of the personal suffering from the patient, this is an ecological problem as well, because the patients are not be able to work, so they are not making money. It's a huge problem. And we have, of course, we have antibiotics, but we have the problem with the antimicrobial resistance. So every approach which is helping us to reduce the number of infection is very important for us. And we have for OM89, we have already good data, so we can support its usage. Thanks.
Well, thank you very much for those final comments from all of you. And I think that the world is a better place for the work that you're doing on this topic. And it's been wonderful talking with you today. I'd like to once again thank OM Pharma for their support of this initiative, and of course to you, our audience, for joining us to hear about this important topic. Please learn more about it, and in the interim, stay safe, stay well. Thank you very much, and bye for now.